I'll be giving the next talk. We really thought to introduce this topic of non-invasive tools to monitor the allografts as it's becoming part of our daily practice, but also because many more tools, I think, will be launched in the coming few years. And it's important as clinicians to understand at least the language when we are introduced to a new test and learn how to assess its performance and how to use it. But I think before I start, I think you need to know about my disclosures here, because I'll be presenting a clinical test that's commercialized by Thermo Fisher that came out of my lab, and I have IPs, and I have also I get royalties and grant money for this work. This is not to talk about the history of transplantation, but this is just to say that since the first era of transplantation, we still do exactly the same thing, which is we give an allograft and we treat almost everyone the same, and we wait for complications to happen. If there is a rejection, we say, oh, we underdid it, and then we treat and we increase the maintenance therapy. And if they develop infection or malignancy, we cut down. So, and this is, I think, what we do currently is really a hand-waving approach between too much and too little, and this is why our patients are not doing well. We really don't have a tool that tells us how active is the immune system against the graft and how to tailor the immunosuppressants we are using. And what makes things worse, I think, what we use as a tool to monitor our kidneys is creatinine. Here is to show you that you need to lose more than 50% of the kidney function before you start seeing creatinine. And I admit that I've been a victim to this many times, where I have patients with stable kidney function, and all of a sudden their creatinine goes up, and when we biopsy them, they have really advanced disease. So it's very important to know that we need tools beyond the creatinine. And we know that from all these studies that showed with protocol biopsy that showed up to 20% of our patients can develop subclinical rejection. And this is very important when we know that the long-term outcome of our patients really correlate with the acute rejection early on. And this is just to tell you that when we talk about biomarkers to detect rejection, we're talking about diagnostic biomarker. But there are many more tools to be developed beyond diagnostic biomarker that are as important, if not more important, like prognostic biomarkers that can predict the outcome before really it happens and allow us to change our management. But also predictive biomarkers that change in response to treatment. One of the major issues we have in transplantation that if you have a rejection, you treat, but then how to follow up those patients, how to know that enough is enough. What most of us do, repeat biopsies, but also on the biopsies, is unclear whether if we're seeing still a little bit of inflammation, this is a disease that is on its way out, or still we have an active process against the kidney. But also, it's very important to understand what are the phases of biomarker discovery. We have the discovery phase, but this is not enough. We need to validate what we find in our discovery in a new set of independent cohort. And what's required is also a prospective multicentral validation. But this step of prospective multicentral validation, many would do after the standardization test part, which is as important. And this is how to ensure that a test done in one lab can be done in different labs and getting the same results. So standardizing the process of doing a test. And this is a very important step to be able to commercialize a test. So it's very important to understand all the steps that a biomarker went through before commercialization. And when we talk about biomarkers, we have many set of ideal biomarkers, characteristics. But what I want to talk about mostly is how to assess the performance of a test. And I think the most important to remember is to know what's the positive predictive value and what's the negative predictive value of any test you're using. The positive predictive value, it's what's the likelihood if the test is positive that actually you have the disease. The higher the positive predictive value, the higher the chance that you can, that the disease is there and you can act, in fact, on the test itself without doing a further testing or a biopsy in the case of a kidney transplant. Negative predictive value, it's if the test is negative, what's the likelihood that you don't have the disease? And this is very important for rule-out test. So if you have a test with very high negative predictive value, is also very useful because, if it's negative, there is no active issues in the kidney and you may not need to biopsy. But what's very important to know that the positive predictive value and the negative predictive value are dependent on the prevalence. If the prevalence of the disease we're looking for is low, this brings the positive predictive value of any test lower and the negative predictive value higher. So it's very hard to develop a test that has both high positive predictive value and high negative predictive value. This must be a either multiple test or multiple signature test. But another major issue in transplant that we all been had in our career is that the sampling error of a biopsy. This is an example of a patient who we thought that there's something wrong going on. Creatinine plateaued at around 2 and never improved. Then we biopsied this patient and had no rejection. And then 2 weeks later, the creatinine did not improve. So another clinician decided to rebiopsy again. And this patient basically had, in the second biopsy, that's only 3 weeks apart, had ACR and AMR with de novo DSA. And this must have been going on for quite some time. So most likely the first biopsy was the sampling error. And imagine, we're asked when we develop biomarkers is to assess that compared to a gold standard. And the gold standard here is a biopsy. But the actual biopsy is not true gold standard. There is sampling error, but also there is a variability in the how to interpret these biopsies. If you look at, pathology, there is up to 20% variability in their reading for biopsies. So, and I think we owe the advances in this field to our understanding of biology. When we talked about in the morning how those clone of T cell recognize an alloantigen in the secondary lymphoid organ, but they home to the tissue through the peripheral blood. So really we can sample this process either through the peripheral blood or by doing a biopsy, or through the urine in this unique case of kidney transplant. I would argue that the signal you get in the blood is diluted. You're talking of a billion clones of T cell. Not all are reacting against the alloantigen. And then in the urine, I would argue that the urine is coming directly from the tissue and must be the signature of any disease must be concentrated in the urine. So I'm going to talk very quickly, mostly on tests that are clinically available to us and then we are all using in the clinic. I think the cell-free DNA is the most commonly used test, and I think the rationale behind this test is very strong. You have all our cells decay and release DNA, and this DNA make it to the peripheral blood. In the case of if you have a kidney transplant, the DNA of the donor are different than the DNA of the recipient. So there is ability to differentiate the DNA and the cell-free DNA in the blood, donor from recipient. And this group showed that if you're at steady state, when you have no issues in the kidney, the ratio of donor to recipient is less than 1%. However, if this ratio goes above 1%, this correlated more with rejection. However, this is an injury marker, and then here they looked specifically at rejection and excluded other cases of injury. But if you look at the performance of this test, and this is how you need to assess any test that come your way, the negative predictive value is 84%. 84%, which means that if the test is negative, you have 84% chance that there is nothing going on in the kidney. So, but still there are 16% chance there's something going on. However, this result come if they after they excluded 1A rejection. So this is, if you add the 1A rejection that were not detected by this test, the negative predictive value is significantly less than that. So if the test is negative, you still have a high chance or some chance, some significant chance that there is some issues going on. The positive predictive value is relatively good at 60%, and this means that in 60% of the case, if you biopsy, you would see a rejection going on in the kidney. But after this initial study that gave them the FDA the CMS approval and been widely used, there are multiple prospective studies that have been done, including the Admiral study, that showed that the utility of this test over time. But I just wanted to, this is data from 1,000 patients. But when you look at the detail of the data, there are many exclusions. So if you look at how many patients were excluded in this study and how many patient made it to the final analysis, that basically makes the data hard to interpret. However, this is a study from the Lupi group in Europe, where they developed this clinical an algorithm based on clinical parameters that we all use to assess immunologic risk of patient, and this in fact performed by itself very well to detect rejection. However, if you add the cell-free DNA to it, there is significant improvement on the clinical judgment, in another word. So there is a utility for using cell-free DNA. I use it in my clinic, but you have to understand the limitation of the negative predictive value of this test, that you can be missing rejection, but also that in the positive, the instance of positive result, there is the other diseases that can cause injury to the kidney can be causing this elevation. So I'm going to talk about another test that is in fact FDA approved. This is one of the first tests that have been FDA approved in transplant for immune monitoring. And this is the immuno test. And the rationale for this test is based on the fact if you have inactive immune cells, those immune cells will be producing a lot of ATP as the essence of activating those cells. And if you measure the ATP, you can assess the how much the immune system is active in a particular patient. And then this is what they did. They isolated CD4 T cells from the peripheral blood of patient, and they stimulated those cells with a non-specific stimulant, and then they lyzed those cells and measured ATP production. And they were able to, in fact, show that there is a correlation between the level of ATP produced and event. The patients who developed had very high ATP production had higher risk of developing rejection. Patient who had lower ATP production has higher chance to have infection. And then they set those threshold of positive and negative, and then this zone in between for stable patient. But as you can see, that there are spillover. When you talk about the group, yes, it correlates well. But when you're talking about one individual that you want to make a decision on, it becomes harder, because you can have someone with a normal level and even low level, but still can be rejecting. However, this test has been used in, and many studies showed later that the correlation with infection has been very strong. So if you have consistently very low level of this ATP in patient, that those patients had more opportunistic infection, including BK infection, as shown in the study and others. And I personally use it mostly in patients who I think they are immunologically over immunosuppressed, and then I want to take them. I want to reduce that immunosuppressant beyond our protocol. So I usually run this immuno, and if the immuno is consistently low, I reduce the medication beyond our protocol. So now we're going to move to the peripheral blood, and then molecular signature on the PBMCs. So with the same rationale, if you take the peripheral blood and you measure multiple genes that are activated in those immune cells during rejection, you can have a signature that correlate with immune activation. And many groups attempted to do that. This is one clinical test that initially showed good result, but then in subsequent large multicenter study failed to show utility. The same applied for another trial test, TrueGraph, and I'm not going to spend a lot of time on that because similar story. Again, the idea is that in the peripheral blood, maybe the signature is very diluted when you talk about, billion of clones of T cells, and some of them are activated against the graft. But the AlloMap, as you may know, used for heart transplant seems to correlate very well, and now we need more data in the kidney transplant to really understand what the performance of this AlloMap will be. So I will move to the urine. And again, my bias to the urine, that the urine is coming directly from the tissue and may have a high concentrated signature. And you must be, most of you would be aware of the work of Sotantiran group from Colombia that has the rationale here. If you have a rejection and immune cells infiltrating the kidney, some of those immune cells will make it to the urine. So if you take the urine, you centrifuge, you take the cell palette, and you look for genes that correlate usually with immune cells, that this will correlate with rejection. And this is the case, like a CD3 in this case, IP10 and others. And this basically test went through multiple phases, went through discovery, then went into amazing validation, and showed to be a good test that can perform very well. However, this is basically, in 2013, and still this test is not in the clinic. And the reason is mostly because of the standardization phase. As I told you, the cell palette, those cells are decaying very quickly, and the RNA will be exposed to RNAs, and the RNA will decay very quickly in those samples. So if there is one group that is well trained to manage this urine, then you will have consistent result. But when you will deploy this to the outpatient clinics and different centers, then it will be very hard to standardize the collection of this urine, and you're gonna get decay of this RNA, and then harder to commercialize this test. And I come to this field studying those extracellular vesicles, and all our cells shed those vesicles either through ectosomal processes or endosomal processes. You can see here, like the cell membrane is blabbing off, forming a vesicle, taking protein, RNA, materials from the cell. It's like a piece of the cell being released from the cell. And we and others have shown over the years that those important in cell-cell communication. And if you take the kidney, for example, you can imagine that all the cells within the kidney can release those vesicles, and those vesicles can end up in the urine. And if you look at all the materials that are inside those vesicles are truly, rich of marker that reflect the state of the cells within the kidney. So if you can analyze those vesicles from the urine as if you're analyzing those cells within the kidney. So this is the true concept of liquid biopsy we talk about in biomarker. And then this is to show you how active this process is. This is imaging those vesicles released by a cell, and it's calculated that more than 20,000 of those EVs are released by cell per day. So very active process in health and disease. And I come to this trying to understand how T cells communicate. To do that, we had to culture immune cells, non-immune cells, and isolate, optimize technique to isolate those vesicles and characterize them. And very quickly we realized that those vesicles carry on their surface a canonical marker that traces them back to the cell of origin. And in this case of CD3 is a marker of T cell. So you can see that the vesicles released by T cells express CD3 on their surface. We can image them. We can do that in multiple techniques. But this applies to other cells like B cells. We show now for endothelial cells, epithelial cells, and others that carry canonical marker that allow us to trace this back to the cell of origin. So the first question we ask, if you have a rejection, you have cells infiltrating the tubules. If you have EVs released from those T cells, can we see them in the urine in the context of rejection? And the answer is yes. We showed that many years ago, and we developed multiple techniques to point of care technique to identify those vesicles through microchip, and this is part of Acro Inc. company in Cambridge. But then to me that was beyond that. So this is our data, but this has been shown now well accepted in the field that the RNA inside those vesicles are very stable. Different than the cell palette where the cells are dying and the RNAs are destroying those RNA. Those RNA inside those vesicles are shielded, and with that they remain stable over time. And we did this experiment. This has been reproduced by many centers around the world, where you take a urine, you put it at 4 degrees, and you come at different days, you isolate the EVs and you isolate the RNA, and you have a stable signature. And to me, that was critical to develop a test, because of you can expect that you can standardize this test to be used as a clinical test worldwide. And this is where we started our discovery and early validation. What we did is we took those urine from patients who underwent for-cause biopsies. Some had rejection, some had no rejection. But really, we excluded cases other than the rejection process. And as you can see here, most of our rejection were early rejection. This is what we see in the clinic, mostly 1A rejection. We isolated those EVs, we isolated those RNA, and we did a high throughput analysis and very quickly identified a multi-gene signature that correlate with the rejection. But the beauty of molecular signatures that can give you an idea about the processes that's happening in the tissue. And so we were able to identify a signature that can differentiate also between ABMR and TCMR. And now we have signature that differentiate also with other inflammatory diseases. So if you do single cell analysis, and this is data from our lab, and then you run pathway on those immune cells, but you take EV from the same patient, and you do RNA sequencing and you run the pathway analysis, you get similar hits, showing that those EVs are really reflecting what's inside the tissue. But that's not enough to develop a urine test. This is basically, we are here. And then, so we needed to do external validation and prospective validation first. But what we did first, we moved this test to a clinical platform to ensure that we can standardize the test and we can deploy it in different labs. And with that, all the genes were exported successfully to a QRT-PCR that's available in all labs in the country. And we did another validation study for transplant centers. We had for cause biopsy, but also we had a cohort with protocol biopsy to see how this test behave in subclinical rejection. But what we did, we ensured that we don't exclude any biopsies, and all biopsies, whatever the cause, make it to this analysis. We wanted to really know how this test will behave in real time. And we basically, the way this test is we measure the CT value of every gene, we import it in an algorithm, and we generate a score from 0 to 1. Each column here is a patient, and as you can see, the higher, the gray here is no rejection, the blue is rejection, and then the higher the score becomes, then you have the corresponding patient is developing rejection. But as you can see, we had a lot of patients that, in fact, above the threshold but did not have rejection. And when we looked at that, we found that most of those patients have significant inflammatory diseases, whether BK or incisional nephritis, recurrent GN, even a case of PTLD made it to the test and was tested positive. And to me, that was a positive result in a way that all inflammatory diseases that clinicians need to know about are being captured by this urine test. But again, we still had biopsies that were normal, but still the urine test was positive and the inflammatory signature is high. So we looked at those patients in particular. So remember, those patients have normal biopsies, but their level is extra, or the test is positive. When we compared those patients to patients who had the biopsy also normal, but the test is negative, we found that there is a significant difference in outcome. Those patients who have the positive test, even if their biopsy is normal now, had worse outcome. They either rejected later or developed DSA, dropped their GFR, and lost their grafts over 5 years. So this showing that this test has prognostic value. But also we had patients who had the test, had rejection, positive, had rejection, treated, and then we looked at what happened to those patients after treatment. Patients who score basically significantly went down, those we call them the responders, had significantly better outcome than patients who did not respond, where their score remained high even after treatment. So giving us that this test has also a predictive potential. But this is not enough, and I don't have time to show you all the data, but we showed that it had the same performance for subclinical rejection, and also we showed if the test is positive at 3 months after transplant, even if the biopsy was normal, those patients did not do well over the long run. And then again, this is not enough to launch a clinical test. So this was transferred to Thermo Fisher lab, and they did their external validation, which also showed similar result to what we have. And the test now is called, instead of ExoTrue, is called ECTRA, and this is commercialized through Thermo Fisher. So I want to go back. I think I have a few minutes to tell you a little bit about our experience with this test at the Brigham, because we're using it in the clinic. And what I did not tell you when I showed you this case where the early biopsy showed no rejection. In fact, we did the biopsy because the ECTRA was very high. So the ECTRA was high, we did the biopsy did not show rejection. However, 3 weeks later, this patient has been re-biopsied and had a severe rejection, showing us that basically those molecular signature may in fact at some point start performing better than the biopsy. This is another case of how those kind of inflammatory tests can be used. We had a patient who had, NPGN, had a lot of immunosuppression in her lifetime, received a living-related kidney transplant, then developed PTLD. And with that, she was treated, but her immunosuppressants were reduced significantly. And she's been very stable, but at a very low level of immunosuppressant. And the question she had to us, what should I do? Should we increase the immunosuppression again now that everything is stable? How can we prevent chronic rejection and shortening the half-life of this kidney? So we ran the ECTRA, and the ECTRA was very low in this case, and we decided to keep her on lower dose of immunosuppressant. So this is giving us an idea about how active the immune system against the kidney are. And then what we found so far with this test is an excellent rule-out test. If the test is negative, there is significantly more than 95% chance that there is nothing going on in the kidney. We have many cases where patient had stable kidney function, no proteinuria. We done the ECTRA and was positive. We ended up biopsying them, and we had many cases of those patients having rejection, in fact, up to a 2A rejection, which was very surprising to us. We had some cases of the cell-free DNA is negative, but the ECTRA is positive. Those usually are patients with interstitial inflammation and ACR. We know that cell-free DNA doesn't do well with those, but also after treatment, We had patients who their cell-free DNA normalized, but not the extra. And when we rebiopsied them, they still had AMR ongoing. We saw that patient with IgA recurrence had positive tests. So with even in the absence of proteinuria and hematuria. And I think this could be another way to monitor those patients. We had patient with, obviously the extra was positive, but the biopsy normal. And I personally consider those patients high-risk patients, and I continue to follow them very, very closely. However, there are limitations for this test. Patients who have preemptive transplant, who have urine coming from the native kidneys or from a previous kidney transplant that has an inflammatory process, may get false positivity. Our study did not show statistical significance when we looked at that particular specific question, but I have high suspicion that this could be a cause for false positivity that we need to be aware of, and also the presence of urine infection that need to be excluded. And then when we, I put ChatGPT to envision where this test sits on with all the different tests available, and obviously the answer is that inflammation precedes injury. So, it's very important for us to sense inflammation early on and, adapt our immunosuppressant accordingly to prevent long-term injury. And I will stop